A warm welcome to everybody to this fourth GlovoNet Volcova Media Expert session. My name is Tom van Boxtel. I'm president of Volcova, and it's my great pleasure to welcome you all to this event, offering some lectures as an appetizer for the 6th Volcova at 29th and 30th of April of this year, so coming soon. All recorded sessions from this event are still available on the GlovoNet website, www.glovonet.com. For this session, we have more than 1,200 people attending from 57 countries, which shows that there is a strong need for latest information on many topics related to vascular access. All presentations are based on your suggestions. The scientific committee then chose 8 topics for these 4 sessions, offered for free over the past 6 months towards the 6th Volcova. For 2 topics for today, sessions are how to organize and manage a vascular access team, and the other one is how to choose the best vascular access device in non-hospitalized patients. Of course, we want you to actively participate. And on the right side of your screen, in the panel Join the Conversation, you can enter your questions in English. If you like a question, click the thumbs up. The more clicks, the more likely it will be that the question will be answered next in our discussion. But for those questions that are not answered during the session, they will be sent to the experts and will be answered afterwards. Next to our speakers, I'm pleased to introduce our host for today. We have 2 hosts. One is Professor Evangelos Constantinou, and the other one is Professor Mauro Pitiruti from Rome, Italy. For this first part, I want to hand over in a minute to our first host for the first part of this event, to Evangelos Constantinou, a long-term friend, expert, and particularly well-known to teach to nurses to work as a team and to improve vascular access for all patients. And it's a real pleasure to have him as a host, also looking ahead to our future conferences. Our second host from Italy, Mauro Pitiruti, I will further introduce him in the second part of the 4th Media Expert session. But a special thanks go to all our sponsors for their generous support of this event, thus allowing to participate without any registration cost.
As a scientist at 3M, I've dedicated my life to improving healthcare. My father taught me that to find a solution, you have to fully understand the problem. You have to understand people, not only patients, but also doctors and nurses. My team developed a solution that helps reduce the risk of infections during hospital stays. That's how you protect patients and achieve better outcomes. There's more to do, but together, we're working to improve lives.
I would like to start my presentation on how to organize and manage a vascular access team. If we look at first thing, what is important is that I don't have anything to disclose. But why should we organize a vascular access team? And there are several reasons, because we still see that we are facing on see one, do one, teach one, and that is not based on research or new knowledge. There's no innovation on materials and procedures, and it's not state of the art as it should be. And if we look at the many differences about the importance of vascular access, we also see that there's often seen as a generic skill. Doctors in training and sometimes nurses, it says go to the patient and give it a try, often without supervision. Patients are still suffering. Many differences in procedures, many differences in skills, and lack of cost-effectiveness studies, which only often focus on cost of materials. And recently, there was looking at state-of-the-art and best practice techniques, and we all know what it looks like, what we should do. But in a recent publication, which was shared in a forum, it was an open versus ultrasound-guided tunnel central venous access in children, a randomized controlled trial. And this open stands for cut-down method. And we all know that this cut-down method is still done by many clinicians. And it means that we still have a lot of work to do. And one of this is having a team to get this improvement done. So why having a team? There's still a significant incidence of failures, complications, delays, waste of materials, less than the minimum of safety and cost effectiveness. And if we look at some historical publications, then the benefits of an IV team in hospital practice presented or published by Lisa Dougherty already in 1969, she said that IV teams can benefit the patient, the hospital, and the nursing profession. IV teams reduce fear, non-compliance, and infection. Standardized procedures lead to safe and cost-effective care. Given the current rates of complication, costs, waste, and insufficiencies in current procedures, there is a little doubt that each hospital or medical center must devote attention to infusion therapy, an invasive therapy that touches virtually all patients entering the facility, published by Lynn Hathaway in 2013. A vascular access team can help achieve the goal to improve vascular access for patients. Oops, sorry. What is the definition then of a team? A group of people with different skills and different tasks who work together on a common project, service, or goal with a meshing of functions and mutual support. But it can also be a group of individuals, human or non-human, working together to achieve their goal. And specialized teams have demonstrated unequivocal effectiveness in reducing infections, complications, and costs on infusion therapy, published by CDC in 2011. In the INS, the newest standards of practice from 2021, early this year, a group of clinicians is centrally structured within the facility, charged with the goal of accuracy, efficiency, and consistency for delivery of infusion and vascular access services. Staff mix varies. However, this team should be led by a registered nurse. This is INS, Infusion Nurse Society, specializing in this practice. Scope of service, team name, and roles of team members vary greatly. And of course, that is confusing. So infusion therapy requires interprofessional collaboration along all clinicians. The scope of services provided by the infusion team or vascular access team is structured to meet patients and organizational needs for safe delivery and administration of quality infusion therapy. Infusion and vascular access services provided in the community follow regulations applicable in each country. A healthcare team, consequently, the roles of the infusion team of vascular access team members include direct care providers, educators, consultants, coaches, mentors, and advocates, coordinators, and managers, also within the INS standards. But we have two parts of a team, a vascular access device inserter and care team, with surgeons, infectiologists, nurses, anesthesiologists, pediatricians, interventional radiologists, and so on. But one criterion is that they should all have the right competencies to be allowed to insert vascular access devices. We should try and do our best to use the same names for PIVC, meaning midline, PICC, CICC, FICC. And if I look at tunneled, it's still questionable because we still talk about Hickman, Broziak, and PICCs to have tunneled options. But in fact, most of the at least central venous catheters can be tunneled, including ports and thorax ports and PIC ports. If we look then at the vascular access devices, we see that all types of peripheral IVs, mini midlines, midlines are inserted by all clinicians. PICCs in most countries are inserted by nurses and doctors, but PIC lines are often not recognized as central venous catheter. CICCs are mainly inserted by doctors. FICCs are not regularly inserted by nurses. Implanted thorax ports, mainly by doctors, not being part of a team. Implanted arm ports, PIC ports, increasingly inserted by nurses. And Evangelos is one great example of inserting PIC ports. And of course, also in Italy and probably some other countries or countries where they will start doing this. But we should think of having indirect vascular access team members. The purchasing department, management with a mandate, the university for advanced training and research, the nursing school, and maybe also patient representatives. But this is a difficult part of the team. Nurses at the wards, home care nurses, because we see an increase on home infusion, and pharmacy. Vascular access specialist team should communicate between all team members, aligning vascular access devices and other materials used, indications, techniques, care, complication management, data collection, and research. Team members should be inserters and indirect team members, following the same protocol and input depending on the role within the team. But we do know that there are many national differences if we look at the different countries involved. There's historical differences, hierarchy, leadership, rules and regulation, with health insurance differences, resources, infrastructure, access to a hospital, and local care facilities. Other influencing factors for managing a vascular access team is the tender structure, which is done in many countries. But therefore, we are forced to use certain products as part of a portfolio, mainly based on price and not on total outcome. The vision structure of one organization, that gives us segmented, non-flexible budgeting. You know, the one is counting material costs, and we often see only doctor fee included. But you can also see that divisions struggle between each other. The one budget should not be taken for another division. And it's depending on the reimbursement structure of an organization and the country. Looking at evidence for a vascular access specialist team, it is quite difficult to find real good evidence. In one Cochrane review from Peter Carr in 2018, the conclusion was that there was a fail to locate any published randomized controlled trials to support or refute the assertion that vascular access specialist teams for device insertion and prevention of failure are superior to the generalist model. And of course, this makes it very difficult. And other evidence for vascular access specialized teams that best practice care is supported by a consistent, knowledgeable, and skilled approach. By Alexandru, Sophia Nash, Jackson, already from some years ago. Some studies include follow-up care, which can include clinical tasks such as dressing replacement and daily assessment for potential removal. Also done by Peter Carr in 2010. Reducing the number of failed needle insertions is an important infection prevention strategy, and one that can reduce patients' stay of length in the hospital. But how to organize a vascular access team? I would say, do your homework, identify the need, identify the options, collect data and evidence, look at cost effectiveness, because that's where we need to have more evidence and studies done. But also include and contact your champions. Who is interested? Who wants to be part of this team? Collect proof for your existence with examples from other centers. And with international collaboration, we do find more centers that have a team completed with all parts involved. Data collection, share results with your board of directors, with your CEO, but also at congresses, publish and do some PR for your team, for yourself, and for patient improvement. Implement the vascular access team in the organizational structure, because if you don't, it can easily be expelled again if they want to save some money somewhere when they think they save money. But therefore, it is needed that you have your own budget, that you have the resources, that you have project funding, like looking at healthcare, health insurance funds, or interested companies. Do research and create the need for expertise, but also work on team relations. And looking at team relations, there should be attention for the social context of the team. Get together, show interest in team members, share responsibility, tasks, and organize team activities like education and social gathering. And recent developments is improving of insertion techniques. You know, we see it with ultrasound or tip positioning, but also we do have Volkova consensus on the use of ultrasound. No more blind sticking, as Jack Ladon often stated and presented on. Prevention of complications on tip positioning, choice of materials, care management, education, certification, etc. And if we look at the future of vascular access in the world, then patients are better informed and involved. There are more online sources available for patients, but these are not always accurate, not always state-of-the-art knowledge. Treatment for patients should or is not different in different parts of the world. So we should have the same approach. And also within disciplines. Why are there differences in vascular access training for doctors and nurses inserting PIVCs? This is not everywhere, of course, but if I look at my background, then I tried to have it in one training, but that didn't work on the long term. increased options for treatment, and global sharing of skills, knowledge, innovations, and research. And what we need is more teamwork. And with more teamwork, we can also ask you to join the Global Vascular Access Team at Bokova at the end of April. Thank you, and I go back to Evangelos if it works now, but thank you for listening to my presentation.
Hello, I'm sorry I have to take the word instead of my friend Evangelos. Apparently, there is a technical problem with his Greek connection that we were not able to fix. So I will step over and try to make the best to comment what is the presentation by Ton, which was really a very difficult presentation. I really admire him for trying to put things clearly, because there is a lot of ambiguity when we talk about vascular access team. In different kind of Europe and world, we have a different knowledge of what a team is. So the first thing I will ask, even before looking at the questions which are coming from the audience, is Ton, do you think that it's possible to imagine a vascular access team which cover all the vascular access of the hospital? Or do you think that this should be a vascular access team specialized exclusively in ultrasound guided vascular access from the hospital? This is also from a question from Australia, from one of our friends, which asks himself, there are a large number of nurses in all worlds trained in ultrasound guided insertion of peripheral IV. And what should we do about it? Should be this many small dedicated teams, or should they try to convey their experience in one unique vascular access team? I know it's a difficult question.
Thank you very much, Mauro, for this question. And I apologize for Evangelos not being directly there. But looking at this question, you know, my experience is that I was part of a hospital purchasing team. And that's where we had contact with different disciplines involved in improving the team effort. I think that if we look at a vascular access team, and I mentioned that there are two parts there, that the indirect involvement is very important and can be done if people of the inserter team can be and will be also be involved in the other parts. Take, for instance, the insertion of ports, which is often done by the surgeon. But if there would be communication on what to do and how to do it, and at least be part of the communication, I think communication and education are the two main parts here to improve the team effort. If you look at the team itself, then inserting only peripheral IVs and call themselves a team, it's also a team. But to cover everything, I think communication and education are the two main issues that should be covered, both at what I said, the university, the nursing school, but also within the organization. So these two parts, education and communication, can be improved.
Yeah, you know that I come from a very peculiar experience from Italy, when there are a lot of teams which are multi-professional, starting from my hospital, where we have a team which consists of nurses and doctors, and practically nurses and doctors that, if properly trained, do the same procedures. You mentioned ports. In my hospital, ports are inserted by nurses and doctors at the same level, and only by a few people. Do you think that this model is the model of the future? Or do you think that in the future will be a further separation between the role of the different professions in this area?
First of all, I think that you have done a unique job, Mauro. And I think that's why I mentioned these champions, if you have a champion in the hospital that is willing to take the lead, and it's important who can take the lead in bringing all these efforts together. But I think, you know, your hospital, Gemelli in Rome, is a good example where all disciplines work together. The question still is, you know, do you have enough involvement towards the purchasing committee, the pharmacy? And I think, you know, those disciplines should at least be involved and feel involved, that they have a role within improving vascular access for all patients. I think that we should not further divide, but we should further unite with more disciplines. And if we overcome the hierarchy, then I think we can actually say we have a team with multidisciplinary involvement. And it doesn't have to be all in the same room, but we need to work together. And that's where this communication is a very important issue.
I think that someone in the audience has already captured this message, because he or she says the best approach, in my opinion, would be a multi-professional, multidisciplinary team, which absolutely we agree with, right? Mm-hmm. But there is another question which is more specific, and I would be tempted to answer myself. But the question is, for US nurses, what is the recommended training for PICC port insertion? And,
you answer, Mauro.
Okay, thank you. Because we did it. In our hospital, we prepared a training course for physicians and for nurses, preparing them to PICC ports. With the nurses, it was somehow easier, because we could take nurses which were already expert in PICC insertion. And the step for becoming PICC inserter and PICC port inserter is very, very small. It's just a question of learning two very stupid things about making the pocket in the arm, which is, on the other hand, I would think that what is happening now in my hospital is very interesting. We are having university courses which are open to both nurses and doctors, and that want to prepare doctors and nurses to PICC port insertion. I strongly believe that a procedure is a procedure, whoever does it. You might be a very poor performer as a nurse, or be a very poor performer as a physician. The problem is that if you really want to learn something and you feel that it's important, you put your soul in it, and you follow a very good training course, then you become a good inserter, regardless whether you're a doctor or a nurse. So I still think that there is a sort of, unequal treatment. I mean, people think about the different aptitude we have between men and women in the hospital. I think that different aptitude between nurses and doctors is even worse. Mm-hmm. What do you think about?
Yeah, I agree. And it has an historical perspective. But I think it's important to have a physician, and I was calling this mandate. But if you look at who can take responsibility for a team, then we still have to look at the structure of the organization and who can have influence. And for now, in most hospitals, in most countries, it is the physician that has most influence, and often be part of the hospital team, the management team. So I think, looking at champions, at mandate, it is good to have the physicians also involved. Not always inserting, but maybe also being in the indirect team to see the importance of having this team.
This is a very good point, because as you said, it's not just a problem of insertion. Insertion is something which happens to be in the area of competence of both the nurse profession and the physician profession. On the other hand, when you do have a vascular access team, you also cope with some situation which specifically require a physician, such as a diagnosis of infection and diagnosis of venous thrombosis, and of course to prescribe the treatment for this complication. So obviously there must be a physician because it will cover. But thinking of the procedure itself, I like to think that the procedures are not diagnostic acts, they are not therapeutic acts, they are just a form of general care to the patient. There is a comment from another colleague about neonatal. Lee says that in our unit we have a neonatal nursing vascular access team specialized in peripheral IV and also PICC lines. I think this is a very good example. Still, in our neonatal intensive care unit, there is a collaboration, as you said, between doctors and neonates and nurses for the sake of the neonates. I think this is very important. What do you think about it?
Well, that's good that you mentioned this, Mauro, because I think that the role differences with nurse practitioners and other roles, increasing specialty in certain areas, is fading the differences between doctors and nurses somehow. You see that nurses are involved in diagnostics. They are allowed to prescribe some protocol prescriptions. So it is fading a little bit. And this also could support the idea that nurse practitioners or specialized nurses can be in charge of the team of inserters, as long as you have this team effort in the communication, and that the education is connected to this team.
Okay, I think that's a very good point. Maybe we should go now to the second part. There are some questions which are very interesting, but we deal with aspects which are not directly related to teams. There are people asking about midline duration and peripheral IV lines and subcutaneous anchorage. So if you agree, Ton, maybe we should skip this question and answer this question in a written form and post them on the website.
Yes.
Maybe we could go directly to the second part. What do you think?
I agree, and I formally close this first part because the availability online is separated in the first lecture and the second lecture. So let me close this first part by thanking you very much for stepping in. First, for stepping in to Gloria as our previous mentioned host, and also stepping in for Evangelos due to the technical challenges that we had. So thank you, and we will look at the other questions and have them in a written communication and publish them on the website. But thank you so far, Mauro, and we will be back in a few minutes after this closing of this part, and then I come back in the second part.
The 6th Vokova is coming very soon. Save the date, April the 29th and 30th.
The 6th Vokova will be different. You guessed it, virtual, but adapted to meet your needs.
The 6th Vokova, we still offer the same quality as before. Over 100 vascular access lectures presented by renowned specialists. Over 100 vascular access posters accessible prior to the Congress.
The 6th Vokova will offer additional advantages. More than 25 companies presenting their latest innovations, interactive contact opportunities, networking opportunities with colleagues and friends.
The 6th Vokova is waiting for you to join. We are hoping to see you at the world's most important get-together on vascular access.
The 6th Vokova is available for only €240. This fee covers the full 2 Congress days, plus 3 extra weeks to rewatch so you don't have to miss out on anything covered.
The sixth Walkover is ready for you to sign up. Register now through walkover.com. We look forward to seeing you online at the sixth Walkover.